Hello, welcome to the California Telehealth Policy Coalition webinar on alternative modalities going beyond live video and remote patient monitoring. My name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy. CCHP is the convener for the California Telehealth Policy Coalition. The California Telehealth Policy Coalition is a coalition of over 100 statewide organizations who are interested in advancing telehealth policy in the state of California. It formed in 2011 and it's been increasing and growing ever since. If you are interested in joining the coalition, or if you have some questions or would like more information about the coalition, please visit the CCHP website or feel free to reach out to CCHP staff or representatives from Blue Path Health. Today's webinar will be discussing alternative modalities that are being used to deliver healthcare services that go beyond what we traditionally have seen in telehealth, which is live video store, forward, and remote patient monitoring. Some of these modalities were utilized because of the pandemic, made it necessary in order for certain populations to be able to receive health services, because for various reasons, they may not be able to access the more traditional modalities involved with telehealth. We'll also discuss what the impact on patients has been in using these alternative modalities, the benefits and the limitations, and what we can expect in a post-pandemic era. Today's moderator is Dr. Anthony Magit from Rady's Children's Hospital. We will be joined by a patient who will relay her experiences in using these alternative modalities, and our panelists, which include Lisa Matsubara from Planned Parenthood Affiliates of California, Rajat Simhan from San Joaquin General Hospital, and Sara Schneider from the University of California, San Francisco, Benioff Children's Hospital in Oakland. I'll now turn it over to Dr. Magit. Please note that your microphones have been muted. If you have questions for our panelists, please use the Q&A function. Dr. Magit.
Thank you, May. So I'm very excited about our webinar today. I think we have an excellent group of speakers and that will engage in conversation as they follow up their initial presentations. So I'm going to quickly go through their bios, which are fairly remarkable, and I think you'll appreciate the vast level of experience and diversity that we're presenting in terms of approach to alternative methods for telemedicine. Adriana is our patient student representative, who will be speaking first, talking about her experience. Very much appreciate her taking time to do this. Lisa Matsubara is the General Counsel and Vice President of Policy at Planned Parenthood Affiliates of California, where she works on issues related to access to comprehensive sexual and reproductive health care, as well as healthcare issues related to patient privacy, Medi-Cal, and telehealth policy. She's been a part of the California Telehealth Coalition, as well as working on state legislation related to telehealth, and she is currently one of the co-chairs of the legislative committee of the coalition. Rajat Simhan, our second speaker, is the Chief Integration Officer at San Joaquin County Clinics. He is responsible for engaging physicians and other providers at the clinic regarding health plans as additional stakeholders to improve clinical quality performance and provider satisfaction, while also coordinating the integration of the clinic's quality improvement, business intelligence, and health informatics units to ensure efficiency and alignment with the clinic's business needs. And our final presenter is Sara Schneider. She is a licensed clinical social worker working as a clinician at UCSF Benioff Children's Hospital in Oakland, participating in the Youth Uprising Health Center. She has been providing direct care for youths ages 5 to 21 for the last 17 years, tremendous amount of experience. Prior to coming to Children's Hospital, she worked in group homes and residential care facilities, mobile response teams, community-based services, and non-public schools. At Children's Hospital, she first worked for the Behavioral Emergency Response Team before moving to the school-based program. So I'd like to start off with Lisa, and please, present your work that you do with telehealth in your current role and where you see telehealth going as far as alternative platforms for communicating with patients. And Lisa, thank you very much for joining us today.
Hi, Dr. Magit. Thank you for having me. I'm really excited to be here to talk about telehealth and other alternative modalities. So just as a sort of introduction, Planned Parenthood Affiliates of California leads the statewide public policy and advocacy work on behalf of 7 Planned Parenthood affiliates in California. Together, they provide nearly 1.4 million visits a year across over 100 health centers throughout the state. We really work to advance access to sexual and reproductive health care. And then on our advocacy side, we work to make sure to defend reproductive rights before the California legislature and other governmental agencies. We're really very lucky to have a robust presence in California, and the California affiliates combined see about 1/3 of all Planned Parenthood patients nationwide. PPAC really serves as a collective voice of the 7 affiliates to make sure that we effectuate our statewide advocacy. And in that role, PPAC actually has been very active in the telehealth space, even pre-pandemic, as well as alternative modalities, including asynchronous care. So I'm gonna sort of talk, I guess, to start with regards to kind of what happened in this past year. As many other healthcare providers, Planned Parenthood affiliates rapidly expanded their telehealth modalities as the public health emergency began. So all 7 of the affiliates either launched or rapidly expanded telehealth services within a month of the stay-at-home order, some of them starting even within days after the order was announced. The affiliates really felt very strongly about making sure modalities remained intact, as the services that Planned Parenthood affiliates provide in the state are essential and they're time sensitive. And we wanted to make sure that patients were able to continue to get access regardless of the stay-at-home order. So since the start of the public health emergency, telehealth has represented about 25% of all Planned Parenthood visits in the state. And after the initial sort of stay-at-home orders, as there were we were able to bring back more of our in-person services, but a lot of it continues to be provided via telehealth. And some of the affiliates, it kind of depends, but some of the affiliates do almost half of their visits now through a telehealth modality, whether it's video or audio only. I would say that more than half of our telehealth visits are actually audio visits. And I think as we look into the future, it's really, really important to think about sort of what we've learned during this public health emergency. And so I think for health centers, Planned Parenthood health centers, it's really always very important to make sure that patients can access care where they are. And so, as I mentioned before, even pre-pandemic, Planned Parenthood was really involved in pushing for reimbursement and advocacy regarding telehealth services. In particular, we have an app-based system for hormonal birth control that has been in place for many years, and it's called PP Direct. And so that's a service that has been provided for years. And then obviously during the pandemic, we saw the use of that service increasing exponentially. Unfortunately, for a long time, many of these modalities were not available for Medi-Cal beneficiaries because there wasn't any way for reimbursement for any of these alternative modalities. And that was something that rapidly changed during the pandemic, thanks to certain legislation that was put into place that allowed for that to happen as soon as a public health emergency was declared. And so we were able to really shift quickly to provide that modality for all the patients. But I really think that what we've really learned during the pandemic is, I think what we did not predict was many patients we initially thought would actually prefer to have video visits. And it actually turns out that that's not the case. And it's not just that patients may have broadband issues or other technological issues, but it really became clear that patients preferred audio only services. And there's a really wide range of reasons why patients really prefer this modality. But we've found that many patients don't feel comfortable showing their house or Many of them don't have privacy issues, want to be able to walk away from a computer or a video platform to be able to get to a place where they can actually get their care in a more private place. And so that's been something that we've learned. And I think going forward, when we think about putting together policy, telehealth policy going forward, it's really important to make sure that we're, centered on patient preferences, and that we learn from some of the things that we've discovered in this past year, where we have been able to provide all of these alternate modalities. So I'm going to stop there so I can get other people's, have a chance for other people to weigh in, and then happy to be around for the panel later.
No, Lisa, thank you very much. And I would encourage people to use the Q&A function on the Zoom meeting to put any questions that we can address later with our panelists. I'd like to now go to Adriana. Again, really appreciate your perspective as a patient who receives services via texting. And if you could just talk a little bit about how you came to using texting as a way to receive healthcare services, and what you felt were the differences between in-person visits and what you felt were the positive aspects of this alternative method of communicating with your providers and some of the downsides.
Okay, hello everyone. My name is Adriana. Just a few things about me. I just graduated from Skyline High School, and then in the fall, I will be attending the University of Arizona. I have been using therapy services for like my whole entire life, off and on, but I didn't take it seriously until my sophomore year, which had a big part of the tech service, because there were days where like I wasn't able to go to therapy and physically go there. And sometimes, like, ever since I was younger, my parents, well, my family basically has been against going to therapy. So I feel like when I have access to tech services, it made me feel more comfortable, and like I was able to like vent to my therapist. So I feel like if I didn't have tech services, I wouldn't be able to function, if that makes sense, because I wouldn't be able to have that support system that I needed. So I feel like that's a good reason why we should have it, and that's where you should keep it, because sometimes people don't like talking in front of their parents or like their siblings, or some people don't like having that comfortability to be around people, or like some people don't even like talking on the phone. I was one of those people once at a time, like, so like I feel like tech services really help and really need people, so don't get rid of it. You should keep it.
Adriana, was the onset of your use of texting, was this after the pandemic began, or are you texting even before the pandemic with your therapist?
Both.
Both.
Before the pandemic even happened, that was like my main way to communicate. But if I didn't have ability to go to therapy, like it physically, but then when the pandemic hit, I was like, oh my God, how am I gonna like go to therapy? Like, I don't know, because I hate talking in front of my family about like my feelings and stuff like that. So I'm like, that was the first thought that I had. I was like, I don't know how I'm gonna do this. But then I have my phone where I can text her and be like, hey, I don't feel comfortable talking right now because there's too many people in my house. Would you mind just texting? And it worked completely fine. And I felt so comfortable.
Thanks. Would you consider, if it was one-on-one with your therapist, do you see a benefit to having in-person visits with your therapist on a one-on-one basis, or do you feel that texting is actually equivalent?
Yeah, I think it's like the same, the equivalent of it, because it's just, of course, that you obviously want to be in person with someone so you can see like their reactions to things. But if you're like desperately need someone to talk to, or like if you're in that moment where you're just like, I don't know what I'm about to do, that's how terrified I am, just giving someone a text and making sure that they respond is like the best feeling in the world.
And one last, do you still have face-to-face visits with your therapist, or any type of video visits, or is it exclusively texting?
No, sometimes I do have face-to-face visits over Zoom.
No, excellent. And no, thank you very much. Any suggestions that you would have? Do you feel that texting and in-person both have their places, and you would prefer having these continue on in the future, equal accessibility for texting and in person?
Yeah, like for some, because I know there's some people that really hate talking over the phone, like it's a burden on them. And like some people are like insecure about like the background noise that they have at home and stuff like that. So I feel like texting has a really big part of that. And like sometimes it's just more convenient for that other person.
That's excellent. And any other things you'd like us to know? I mean, one of the things we like to do as a group, I'm sure you're aware, is advocate for continuing to support, various modalities of telemedicine, both from a payment standpoint. So your comments have been fantastic. And please, if you are able to stay around for the discussion, that'd be wonderful to participate with the other panelists.
Okay.
Thank you very much. And I'd like to now turn to Rajat Simhan to give perspective regarding alternative methods for telemedicine communicating with patients.
Thank you, Dr. Magit, and appreciate the opportunity to discuss our experience with the alternative modalities. Just in terms of background, San Joaquin County Clinics is based in Central Valley, California. We are organized as an FQHC lookalike, serving about 40,000 members assigned to us from our partner health plans. Just like what Lisa suggested in her opening remarks, we had to pivot quite quickly once the public health emergency was announced. And due to the legislation that was passed by the state and CMS, we were able to quickly take advantage of the alternate modalities. I feel one of the biggest benefits of the pandemic in terms of delivering care has been the acceleration of telehealth visits and other modalities. I think in the past, CMS has been lukewarm towards the idea of reimbursements for televisits, especially in a Medi-Cal setting. But I think the technology has leapfrogged, and it's probably leapfrogged about a decade in my experience. And at least during the calendar year 2020, I was just running some data. Almost half the visits were televisits, whether it's whether it's video or audio. I think a large percentage of that, almost 45% in our case, was audio only, and that trending continues to occur even after vaccination efforts have started and people are feeling a lot more confident to venture out. So in terms of recommendations, I think we're still not completely out of the woods when it comes to the pandemic, and CMS and DHCS should be as flexible as possible to allow for community health centers such as FQH, like San Joaquin County Clinics, to be flexible enough to deliver care to their patients. Most of our patients have difficulties in terms of transportation to come in to see their doctors for in-person visits. The televisits have been a godsend in that regard. We've been able to still keep our productivity levels high because, as most of you know, FQHCs have to have a certain level of productivity in terms of being fiscally solvent. So in a nutshell, I think the experience to have alternate modalities has certainly helped San Joaquin County Clinics to pivot quickly and to be able to continue to deliver care to its patient base during the height of the pandemic, and continues to do so even after.
Thank you, Raja. And our last speaker, Sara Schneider, and then we'll open up for discussion. So I think Sara has some very illustrative slides to provide to set a background to her comments.
Thank you so much. Really glad to be here. Just wanted to give you a little context of, who I am, where we are. So the first slide is just, we are two FQHC, federally qualified health centers, operating out of the McClymonds High School campus and the Castlemont campus in West and East Oakland. And we serve adolescents age 11 to 21. So we work primarily with young people. And then I'll go to the next slide. At the health centers, I mean, we provide a wide variety of services, mental health, psychiatry, as well as we have social work, we have health education and primary care. So, you know, we've got a lot of different services all working together to support youth in the community. We do also support with the teachers and the staff. And all that to say, you know, working in the community and working in a dynamic environment, we're never going to want to give up in-person visits, like being on campus, being in schools, collaborating with the community center next door, you know, having walk-ins, being able to support young people in person in their visits is critical. But also being able to provide that combined support with the technological services is really important. I'm going to talk primarily about delivery of services through text message, but you know, I think we have seen significant participation in telehealth services, you know, from day one. You know, we got sent home from school on a Friday and we were doing telehealth services by Monday. And, you know, I think one of the young people said, you know, I sometimes had to take, you know, 2 buses or pay for an Uber out of my own bank account and, you know, to get to therapy. And sometimes I didn't have the money, or, you know, it was hard to get there. And, you know, but therapy is so important to me. And when young people have access to a variety of strategies and methods for receiving services, it just creates health equality, it creates more access, and it really supports their participation. So I'm going to talk a little bit about text messaging. So if you go to the next slide. You know, I want to say, you know, there are definitely some things that we have to be very thoughtful about, you know, when we're texting. And I think as we've shifted over into all these different telehealth services, that young people operate with a variety of, you know, some of them are on WhatsApp, some of them are on Duo, some of them are on Instagram, and they all are messaging you through different things. And we have to be thoughtful about HIPAA and confidentiality and how we're communicating with young people, and really taking that into consideration and having conversations with them about how they can reach us, when they can reach us, that there's got to be a container, that we're not just available 24 hours a day. And, you know, when we're thinking about safety, you know, these are all things that we have to think out and map out. And we have young people sign a waiver saying, you can communicate with me via text message, but you know, just know that I can't 100%, that I'm not always going to remember to put my phone away, though I'm going to make the best effort possible. If you text me and my phone is sitting on my desk, you know, I can't guarantee confidentiality. And if we start texting about a safety situation and you stop responding, what is going to be my responsibility there? Well, we're going to have alternative contacts in place. We're going to have caregiver agreements that if I can't reach this young person, you know, they stop responding to me, that I need to, you know, be able to reach a caregiver. If somebody reaches out to me in crisis, one of my first questions is, where are you and how can I reach you? Because I want to establish safety. I want to create a container. I also tell my young people that I am available 9 to 5. You can text me outside of hours. I will not respond until the next day. But I will get into, you know, some kids use that. They text at 3 a.m. because they've got something on their mind that they don't want to forget to talk about. And having that, even if they're able to just use it to download their thoughts, their things, their priorities, what they want to talk about, sometimes that can be really helpful and can be an important lifeline. I was kind of informally polling clients and fellow clinicians about how do you use text messages, and the wealth of answers that came out, we tried to put them into categories. I mean, primarily is safety. When there's a risk, when there's suicidal ideation, when there's self-harm concerns, being able to offer that support. You know, DBT, we've really moved into using DBT, dialectical behavioral therapy, and there's coaching that is built into that. I think if you're using formal DBT, you are available 24 hours a day. But even if you're not, even if you're using some of those strategies, to be able to provide coaching, reminders about coping skills, you know, as young people are entering that escalation curve, to be able to offer an intervention that cuts off at an earlier stage of that escalation, whatever the safety, the risk, is critical and incredibly important. We can remind clients and caregivers of safety plans, remind them of their supports, text additional phone numbers. It's been very important that way. We also use it for larger kind of general coping around hygiene, attendance at school, coaching, you know, reminders about plans that we've put in place. What is your bedtime routine? Medication management? What are your follow-throughs for this week? You know, we talked about having that conversation with this person. You know, we met on Tuesday, on Friday, I'm saying, hey, just a reminder, you were going to talk to your mom about that thing. managing impulses, not just around safety concerns, but I had a young person text me on her break at work that she was so frustrated with her boss and she was about to go off and about to yell at him. But we texted in the back room and really helped her to calm down, think it through. And even when I'm not available, I'm finding that young people just having to text out the story in the situation helps them to slow down and breathe and take a minute, and waiting for a response can slow down the process and allow people to think and respond in a more thoughtful way. We use it to track behaviors. How often is this occurring? How often are these thoughts coming up? It's really helpful with CBT. It's a collaborative way that we can see how often these things are occurring. I think just regular support, it helps keep people on track with their goals. And then access, I think we've found generally, but obviously more in the pandemic, that sometimes the phone service gets cut off. You only have Wi-Fi. To be able to text when you get to Wi-Fi and let your therapist know what's going on. Sometimes they don't have enough room on their phone to download the Zoom app. There's a lot of different things and situations that come up that our young people are facing where access is really challenging. And so being able to have text message as a consistent and free method when they have access to Wi-Fi has been a really great way to increase regular communication and participation. I think Adriana spoke beautifully about confidentiality, during the pandemic. So many times young people are in close proximity to family. They don't have privacy for their sessions, and that they can use this as a way to communicate in a confidential setting. I've also had young people text questions that they're too embarrassed to ask, things about sex, things that are, awkward things about risk and wondering about what do I do in this situation? And sometimes they weren't necessarily brave enough to say it directly in their session, but a text message is a safer way to ask that question that they're a little bit worried about asking directly. We've also used it just to note accomplishments. I get text messages all the time, pictures of a new baby sister's arrival, a link to a virtual graduation ceremony, a screenshot of a job application they just finished, and being able to recognize and celebrate in the moment when those great things happen, it really helps to reinforce positive behaviors. And then the last thing that we came up with was rapport building. Sometimes, especially in the pandemic, when you don't get to meet somebody face to face, a cold call is incredibly difficult. And sometimes starting with a text messages is an easier way to slowly build up a relationship and develop rapport and work up to a phone call. And, a lot of young people are anxious about therapy, and it's a lot less threatening to start building that relationship via text. So those are my points. I thank you all for your time and for putting together this webinar, and I'm looking forward to a discussion at the end.
Thank you, Sarah. I think we have a lot of interesting questions to follow up on, and just as your comments are fresh in everybody's mind, if you could just give it an idea in terms of the response to this modality, texting only, in terms of percentage of your patients, as well as the attitude regarding the providers in terms of responsiveness and how much they like the texting option.
I think everybody uses text. I have a little story. I mean, we had a contract negotiation, and many of the community-based providers were given cell phones. And initially, our program, they didn't think that we needed cell phones because we were school-based, so we were in the clinic, so you have a landline. And we really fought for those cell phones because that is everyone's primary mode of communication. We get texts from teachers who are saying, I've got a student in crisis, like, are you available to come and support? And this is pre-pandemic and during the pandemic. And pandemic, it just became critical. This is how we're reaching out to people. This is how, I've definitely been providing a lot of trauma support and counseling and things to the administration as well, to teachers. We do a lot of coaching and guidance and support for school staff, and that has been important. Parents reach out, they say, I forgot about, this appointment, or I can't find this person's phone number, or can you connect me with, and we can do a group chat. And there are so many ways in which, we're streamlining people's access. We're solving problems immediately. Nobody has to track us down. Nobody has to find us. You know, we can respond quickly and support so many situations in the here and now. And so, you know, everyone uses it and we don't get reimbursed for it. And I think, you know, clinicians are going to do it no matter what, because it is the best quality of care to be able to support our young people and our providers. But I really wish we could get reimbursed for it because it is a significant part of our work.
No, I really appreciate that. And there's quite a few comments about directed towards the panelists in terms of reimbursement. And Sara, we're going to come back to you because you have your experience and really tremendous insights. Rajat, what as the business person perspective, how do you handle the lack of reimbursement in your clinics, and what are some of the ways you anticipate that this could be offset?
Thank you, Dr. Magit. So I think there's been a proposal by the state in terms of probably reducing the reimbursement rate for telephone or audio only visits to about 65%. I think it's our earnest request for the state, and I think California Association of Public Hospitals is trying to work with the state in terms of hearing our voices from a community healthcare perspective. And going back to what Sara just said, I mean, we don't necessarily use a whole lot of texting features, but audio only has been the bulk of our alternate modality visits all through calendar year, and continues to be so for most of our adult patients here at the clinics for Q1 and Q2. We anticipate that if the state is depending on the state stance, and if we're able to not negotiate, we have already started to look at bringing in our patients for in-person visits, which will require that we also bring our physicians and the support staff back to the clinics at full capacity. There's some logistical and operational challenges, and everybody's gotten so used to working from home, and we'll just have to bring them back, and we'll have to do this in a very streamlined fashion. So there's some challenges to do so, but we've started to work with the physician community and also with our access center folks to see if we can start to encourage our patients to come in for more in-person visits. Again, this is going to take a bit of time. It's not something where you just flip a switch and say, all right, we're starting tomorrow, we're going to do a lot more in-person visits. We're hoping that there's more time provided for this transition to happen. I think we've come a long way in this 1 year in terms of adopting these alternate modalities. We are hoping that the CMS and DHCS look at this as another way to provide care. It's been successful throughout the pandemic. There's no reason for it not to be successful, especially in a safety net community, because transportation is a problem. We also, in the Central Valley, we have a tremendous population of seasonal or agricultural migrant workers. They're usually, we've gone to them during the pandemic to do the testing. We also have a large homeless population. And, this has been one of the biggest benefits is we've actually taken, Sprinter vans to the homeless camps and been able to call the doctor and provide the television service via audio only. So there's so many benefits. We just hope that the state and policymakers take a closer look at this in terms of continuing this level of flexibility until we're completely over this pandemic hump.
No, thank you very much. So Lisa, I'm going to turn to you with your familiarity about current and potential legislation, to where you see this going in terms of reimbursement, and what are the next steps?
Yeah, so there's currently legislation that is sponsored by the public hospitals, as well as the California Medical Association, the California Primary Care Association, as well as Planned Parenthood, also Essential Access Health, I believe, and supported by this coalition as well, to really maintain some of the flexibilities that were available for reimbursement in the Medi-Cal space going forward. As one of the other speakers mentioned, that is not what the department wants to do. They do want to the governors may revise budget proposal, which includes what the Department of Healthcare Services, which administers our Medicaid program here in California, they have suggested to pay audio only visits as well as asynchronous. So that would include texting at a lower fee schedule. I know for audio only, they have specified 65% of the fee schedule. I think for Planned Parenthood, we really are hoping to be able to maintain the reimbursement that we've been getting throughout the pandemic. We really don't think that there should be a difference based on modality. It should really be based on the service that you're providing. And if you're providing that service, it shouldn't matter how you actually provide the service, the modality in which you provide it. I will say too, one of the things that is challenging in the space is that, not all of our visits are really 100% telehealth or audio or asynchronous or in person. We have been, especially during this past year, providing a lot of services with mixed modality. So there might be one portion of a visit that occurs sort of asynchronous by text or messaging system. There'll be another component where the patient does come in for like a lab or some other service that needs to be provided in person. And then there might be something else that happens via telephone or video connection. And so it's really important not to have these distinctions in the modality, but rather get reimbursed based on the service that we're providing. And I think that's the goal for the legislation. We'll see as the budget moves forward, in the next few weeks, what will be kind of what the administration is sort of willing to move forward with. But we're very hopeful that we'll be able to continue to provide these services in the Medi-Cal space. I think it's really important as safety net providers to be able to provide the same kinds of modalities that are available to commercial patients should be available to Medi-Cal beneficiaries.
Lisa, is there a discussion about reimbursing for responding to text messaging?
So, generally, there isn't a parsing out in the policy space between text messaging or other what we call asynchronous modalities of care. So that includes emails. Anything that's not in real time is considered asynchronous, and text messaging usually falls into that space. And I think, for purposes of the policy bill that's being pushed by the sort of the sponsor group, the safety net providers, they have included asynchronous as part of that modality. Really, that the whole point of that is that you continue what has been in place during this public health emergency. That being said, the department does have, I would say, a little bit of a strange position on what they call patient-initiated asynchronous modalities. And a lot of times some of these messaging or text messaging pieces are carved out of their policy. So that's something that we would have to continue to work on. And I think for Planned Parenthood health centers, I would say that our asynchronous models usually involve some sort of patient portal or messaging, email through a secure portal or an app-based system. So I think it's important to talk about all those modalities as kind of a whole. And as again, I think our baseline is that if you're providing the service and you're meeting all of the elements of the billing code, then you should be reimbursed in the same way.
Thanks. I'm actually going to call on Amy Durbin. Amy, you definitely have some expertise in this space, and if you just briefly introduce yourself, and looking forward to hearing your comments.
Thanks, Dr. Magit. Well, I think Lisa covered it pretty well. It's the administration definitely wants to parse out all of the different types of modalities, and I think while texting isn't always discussed specifically, it does fall under that umbrella of asynchronous care, and it's not really acknowledged as being potentially the same or treated equally as in-person care or live video care. But as Lisa mentioned, it is in the legislation. And as of, earlier this week, the Assembly and Senate have basically, their budget committees or subcommittees anyways on Health and Human Services have said that they are in support of adopting AB 32 as the language used in the budget when it comes to telehealth payment parity. So I think at this point, that's the policy that most of the stakeholders and legislature seem to be kind of rallying around, and it'll just, kind of move forward at this point to the governor's office and how they decide to kind of bridge that divide between the legislature and the department at this point on, how do they treat telehealth, and if they should be treating modalities differently or kind of look at it based on the service being provided, right, rather than the actual modality in which it's being provided.
No, thank you. And I do want to point, and we'll have that out to the attendees, that in the chat there's some references, information in terms of legislation that's available for you to look at. I'll open this up to Lisa, Rajat, in terms of e-consults. As we talked about texting, audio only, what have you seen in your groups in terms of the utilization of e-consults and the place that they play? I'll ask Rajat to comment on that if you have experience in your clinics.
Sure, I can take a quick stab at it. So we tried a pilot e-consult project here at San Joaquin County Clinics pre-pandemic. And unfortunately, we ran into the pandemic just when the adoption started to kind of tick up. I think some of the providers liked it, but then there were others that, I think we have to be very careful about how we run an e-consult at any facility. One of the biggest complaints that the subspecialists had within San Joaquin General Hospital was in terms of the workflows or some kind of workup that needed to be done before the consult made it to the subspecialist. I think there was some frustration that there wasn't much workup done, so it just came into my inbox and I had to send it back to them. The other thing is we should not be looking at it purely from a utilization standpoint. I think at the end of the day, there should be a value-added service with the patient front and center in mind. And I think that was one of the feedback we received from our specialists as well as the PCPs, because we had a policy where if our subspecialist within our hospital did not get to an e-consult within a specified time frame, then it would roll to the national panel of the particular vendor. And I don't think the PCPs as well as our specialists, because it came back to our specialists and they didn't necessarily like what was provided in terms of an answer. Now, I'm not a clinician, so I can't speak knowledgeably about the intricacies involved, but as a practicing clinician, you could easily pick up on the quality of the consult note that came back. So there's definitely a value for e-consult. It just requires deliberation and also close working with your health plan partners. So what we have started to do is our health plan partner has engaged with another vendor, and we're starting the process of bringing back the e-consult back into the clinics. And we'll let you know how that pans out, but we're in initial conversations at this point.
Thank you very much. Lisa, in your organization, are e-consults used fairly regularly, and how is that affecting care and any barriers that you perceive?
Yeah, I think for our health centers, it's less of an issue in terms of e-consults, although it is something that is used as we try to make sure there's sort of continuity care and seamless care, as well as sort of connecting patients with other services outside of the services that are provided in our health centers. And so it's something that I think we are concerned about at a policy level, especially going forward. And as we start to include more behavioral health services, it's something that I think we are very interested in making sure that it is part of that conversation of making sure that the safety net providers are able to provide those services.
Lisa, I was just curious, do you have a rough estimate in terms of the percentage of your ambulatory visits that use alternative communication methods in person now versus telemedicine?
So, I mean, pre-pandemic, there were we did have, as I said, we had PP Direct, which is a asynchronous model. It's essentially, a patient-centered app that you can actually get some limited services, mostly hormonal birth control, as well as emergency contraception through. So that was something that we did offer. But in general, because Medicaid did not reimburse for telehealth services, it was a very small percentage of the care that we provided modality wise. Now I would say it's about 25%, but it really varies amongst the affiliates. Some of the affiliates do almost half. I mean, I think that's what Rajat said in his facility too. And then of those, I think overall it's about 25%, but I think, 50% in some places. And then of that, a vast majority of them are audio only at this point. So, there are obviously many services that we provide that are not appropriate for telehealth. And so, or as I said before, is mixed modality. So parts of that service might be provided via telehealth, but some of it will be provided in person.
Thanks very much. I was going to ask Sara to comment. Your experience seems so positive with texting. If you have any suggestions, sort of roadmaps for non-mental health providers, I shouldn't say market this to their patients, but really, utilize texting. And the other question I have, and I'll point this to all the panelists, is there any outreach to provide better connectivity? I was just wondering about data use plans. And do you run up against situations where people have difficulty accessing texting on a regular basis, because of either adequacy of access to data plans and where economics come into play?
I think because we primarily, I know we serve kids on either end, but primarily are working with high school students. All of them had access, at least in OUSD, had access to Chromebooks and hotspots. And so a lot of our work at the beginning of the pandemic was really helping to support and identify young people who were either falling through the cracks or were not communicating with the school. Sometimes we had communication with families and young people who the school were having trouble tracking down. So, a lot of our things that we were doing at the start was really trying to make sure that young people had access and making sure that they were set up and, supporting them in that. I think there is no difficulty promoting young people using text messages. They love to communicate that way. And I think it's more like, okay, and let's also, it's got to be both and. It is a fantastic and an incredible support, but also I want to be able to see you sometimes. I want to be able to check in. And so, but I think young people, I think we were really anxious in the beginning about kids not necessarily wanting to sit on a Zoom, but they transitioned. I think when we were just like, this is what we're doing, they transitioned pretty well, and they were like, well, this is similar to FaceTime, so it's not that bad. And because we still have to have face-to-face in order to complete an assessment. There are certain things that we need to do. We have to see you in order to be able to have a complete sense of risk of what's going on. We need to see your presentation. We need to see how you're engaging. Text is not going to be the end all be all, but it is a powerful tool when used in addition to all of the other strategies that we have at our disposal.
I'm curious, was texting, did the use of it happen organically, or is this something that was intentionally offered to patients?
I think it's pretty much just happened organically. As texting has increased, we've just started, and we've been talking about it all along. And it always is. Yes, like texting is not going to be reimbursable. And how do we kind of navigate that? And and often I think because it is not reimbursable, Sometimes we are encouraging young people to like get on the phone or engage in a telehealth session, because if this is going to be a full-fledged session, let's try to have it in a billable structure. But if that's not possible, if this is what the young person needs right now, we will go ahead and we will do it, and we will write a non-billable note. We'll write a quick phone note. We will document it. But I mean, it is hard when you are trying to push a client into a modality that they're not really comfortable and may not be in their best interest, because that is billable. And so I think sometimes we're making those calls, because this is what you need right now, we're going to provide a non-billable service. But it is an important service, and it is, such a wonderful addition to regular telehealth and phone and in-person sessions. I wish we could get reimbursed for it, because I think all of the clinicians I work with are doing really powerful work and using it in so many of the ways that I talked about.
Two quick follow-up questions. Number one, did you create policies, in terms of texting? You mentioned obviously privacy, HIPAA is a critical issue, as well as documentation of the interactions.
No, it's definitely a part of our documentation, and making sure that we're capturing and recording when we're having these conversations, even if they're not billable. Usually we do try to attach it to a regular session, a face-to-face, a phone call, something, or we'll just do a non-billable note, but it is always documented. We definitely have created safety protocols. When I talked about having a backup phone call, a point of contact, establishing where you are if you're in a safe location. These are all parts of our protocol. And as I mentioned, it's now a part of our consents that you are recognizing that there are limitations to text, and that there's limitations on confidentiality, and that, so we have added that too. And it's been in there for as long as I've been here. So, I mean, it's been in there for a long time. So yes, definitely paperwork, protocols, documentation has all changed to reflect it, but the reimbursement has not.
Thank you very much. Rajat, I want to turn to you as we sort of close up here. One thing we haven't touched on specifically are patient portals with the EMR. And obviously this is very dependent on the type of patient and their socioeconomic status and access to internet and actually the portal itself. And wondering how does that work in your clinics? Do you promote a patient portal? And is that something that you see as likely expandable resource for patients?
Absolutely. I think like most other folks here, I think patient portal is a fantastic avenue to enable a two-way communication between the care teams and the patients. We've had, I think, at least since the time I have been onboarded here, at least a couple of attempts, or you can call campaigns, to kind of socialize the concept of patient portal. Each time we've engaged with this effort, we've seen a slight uptick in the adoption of patient portal, but I have to say, it's not something dramatic enough to say this is a system-wide success. There are many reasons for that. Some of it befalls the organization that is promoting patient portal adoption. And then you also have to look at the patient demographics and the patient preferences. In our experience, the EHRs do offer, most EHRs these days do offer that as an adjunct functionality. I think you don't get many EHRs these days that do not offer a patient portal. I think it's almost de facto standard. The patients that do engage, on average, I think about a third of our patient population are engaged in patient portal. Now that dips in, over the pandemic, we've seen a slight adoption uptick in the adoption rates, because we've been able to socialize the questionnaires for intake on the patient portal. For those that are on the portal, they're able to kind of complete those screening questionnaires ahead of time, rather than because it's really hard to do that over a audio only visit, as you can imagine. I think, with the alternate modalities here to stay in whichever capacity, there becomes more of an importance that folks need to do in terms of promoting the patient portal and adoption. We are still trying to increase the adoption rates, and we're working with some industry experts that can provide us some guidance on how we can increase the adoption, but we're still kind of learning the ropes here at this point, I must admit.
Well, thank you very much. So I think I think we all agree there's plenty to talk about in alternative platforms for telemedicine. So as we close, I'd like the panelists just take a minute or two to sort of summarize where you think the importance is alternative platforms for telemedicine and some of the barriers going forward. And I'll go ahead and start with Lisa, and then Sara, and then wrap up with Rajat.
Yeah, I mean, I think we're still, even after this year, I think we're still looking at sort of from policymakers' perspectives, these sort of, I want to say sort of old school ways of thinking about different alternative modalities in terms of providing care. I will say, like, I am really excited about the fact that because we were able to shift into this modality and sort of offer these services to patients, that it's now all of the arguments made before about why this wouldn't work. We're seeing that it does work, and it actually increases access and reduces disparities. And I really think it's a game changer in terms of how everybody views how they receive their healthcare, that we're not all stuck in this sort of mindset that we have to go into the doctor's office or into a clinic to provide care. We can actually get care where we are. And so I think, going forward, I think we really need to start looking at policy, like really looking at it from a different perspective in terms of really making it sure that it's patient-centered. Not to say that we are not concerned about quality or making sure that patients get the best quality of care that they should be getting, but that it's not getting out of this mindset that the only way you can get quality care is an in-person visit. I don't think that's true. And I think we've seen that over this past year. So I'm excited about that piece. And but I think, one of the barriers is these kind of established barriers. I think just throughout the history of telehealth policy, we have always been sort of, the policymakers have been like putting up all these barriers that have made it really hard for people to actually adopt telehealth fully. And we saw those barriers coming down. And now we're kind of seeing from the policymakers like attempts to put them back up again. And I think that's going to be the challenge as we move forward, is like getting people who've been working on this to really like start to change their mindset.
Sara?
Yeah.
Thank you very much, Lisa.
I mean, I think one of the most important things I want us to remember is that, each individual is an individual, and each moment and each day, and, your needs on that particular day are going to shift and change. And some young people really need face-to-face, and some young people can't get to a clinic and need to be able to access it from home. And some have no privacy, and so they want to text you. And we should not be limiting ourselves to one provision, one strategy, one structure. If we can have a whole toolbox, if we can have all of these options and we can play around with it, and we can see you in this way on this day, and we can talk to you, and we can reinforce, these coping strategies through this means, if we can diversify and use all these different tools and these technologies, it means that we're going to be able to provide more comprehensive, better care, and we're going to be able to reach more young people, and we're going to be able to reach people in all different services, or all different levels of need, and all different locations and places and circumstances. And so the more we diversify how we can deliver our services, the more effective we're going to be. And so, I just hope that we continue to grow and recognize that life is changing. Everybody uses their smartphones. There's so much that we can do if we use these tools, and we're not trying to get away or give up face-to-face services by any means. That is a critical part of our work. But if we have technologies and tools that allow people to access and gain the support that they need, like let's use them.
Excellent, thank you. And Rajat, your comments?
Yeah, totally agree. I think Lisa and Sara said it best. I think we have added to our toolkits the availability of these modalities, right? I mean, as I said, I started my comments saying telehealth has leapfrogged through the pandemic. I mean, it's come a long way. There's no reason for us to go back to doing things the old way, especially because it's been effective. We're still here, we're still serving our patients, and they're still interacting with us. So there's no reason for us to go back to just the one way to deliver patient care, which has been in person in the past. I think we have to look at what the pandemic has brought in terms of these functionalities. And I just want, there are some cool apps that kind of help facilitate video visits via a text link that gets sent. And we're looking at one of those, it's called Doximity. It does allow for patients to get a link and then they click on the link and it opens up a video portal. So just like, you know, other entities, we are trying to provide our patients the best, you know, we're taking patient preferences into consideration. And the patients are saying, as Adriana said, texting, audio, we'll just have to be able to meet the patient where they are served best versus just saying, this is the way it works, this used to work this way. We're going back to, I think we'll just have to have an open dialogue and making sure that everybody, including policymakers, are hearing the patient's preference into their policy-making decision.
Well, thank you all so much. And I'm going to turn the meeting back to May for some closing comments. Thank you very much for this opportunity.
Thank you, Dr. Magit, and thank you to all of our panelists who I advise you to look in the chat. The compliments are flowing in for you guys. So that was a great discussion. So first off, I want to thank the California Healthcare Foundation and Center for Connected Health Policy who helped sponsor today's webinar. If you have questions regarding the coalition, if you are not a member and you would like to join, or you have any other questions, please feel free to reach out to me or Amy Derman. That is the link for additional information on the coalition. It's on CCHP's website. And that is it for our presentation today. So again, I want to thank Dr. Magit for his wonderful facilitation and moderation, Lisa Matsubara, Sara Schneider, Rajat Simhan for their terrific presentations, and of course for Adriana for sharing her patient experience with us today. And also thank you to all of our attendees who attended today's webinar. It is being recorded, and the webinar recording and the PowerPoint that was used will be made available a few days after this webinar on the CCHP website. I wish everybody a happy Memorial Day weekend. Please stay safe and please let us know if you have any questions. Thank you.
Thank you. Thank you very much.